Hey everyone, my clinical presentation is on follicular lymphoma. A little bit of background. Non-Hodgkin lymphomas, or NHLs, are a collection of cancers that are derived from B or T lymphocytes, and follicular lymphoma is a type of non-Hodgkin lymphoma that's specifically derived from B lymphocytes. It's a common indolent lymphoma. Indolent meaning that it's treatable over the course of the patient's life, and it's typically non-life-threatening. 74,000 NHL cases in the US in 1 year. Of those, 25% were follicular lymphoma, so it's a very common cancer. And it's characterized when malignant follicles begin to take over normal lymph nodes. The cause of FL is unknown. It's believed that there's an association between FL and a chromosomal rearrangement of BCL2, which may be causing the development or the progression of FL. Diagnosis and staging. Diagnosis is made by a biopsy, and examining the tissue usually reveals three things. One are the malignant follicles that are taking over the lymph node. Two are centrocytes, or smaller looking cells. Three are centroblasts, which are what these arrows are pointing to here. And centroblasts are enlarged activated B cells, and the number of centroblasts can correspond with how severe the cancer is progressing in the patient. So in a microscopic field view, if there are less than 15 centroblasts, that's considered a low grade. If there's more than 15, that's considered a high grade. And FL also expresses CD10 on its surface, and the CD10 protein is an important target that I'm going to talk about later on. To classify FL, Ann Arbor classification is used. A CT scan is used to determine what stage the patient is in. Stage 1 is when the lymph nodes are localized to a single region. Stage 2 is when there are two or more regions of lymph nodes, but they are on the same side of the diaphragm, either above or below. Stage 3 is when the lymph nodes are on both sides of the diaphragm. And stage 4 is when they take over organs and the bone marrow. Patients will be grouped together based on how severe the cancer is, and they're grouped together based on something called the Follicular Lymphoma International Prognostic Index. So the risk factors for FL are that the patient is more than 60 years old, they have an Ann Arbor stage of 3 or 4, their hemoglobin count is less than 12 grams per DL, there's more than 4 nodal regions, and they have an increase in lactate dehydrogenase levels. If there are 0 to 1 risk factors for the patient, that's a low group. 2 risk factors corresponds with an intermediate group, and 3 to 5 is a high group. Management of FL. So like I was saying before, it is a non-life-threatening cancer, which is a good thing. It is treatable, but there is technically no foolproof cure for it yet. And patients typically don't get diagnosed until they are in an advanced stage, because that's when symptoms begin arising. They usually have enlarged lymph nodes, or they may experience fatigue or weight loss. And something that I thought was interesting is that therapy usually doesn't begin until 4 to 5 years after the patient is diagnosed. They're usually kept on surveillance every 6 months just to monitor the cancer. And the goal is to control the management of the cancer to ensure a normal life expectancy as much as possible for the patient. There are therapies if a patient is in an early stage, and those are usually radiation or they're given an anti-CD20 monoclonal antibody drug. And an example of this is rituximab. And the way rituximab works is by binding to the CD20 on the surface of the cell, and that induces apoptosis of the B cell, so it's slowing the cancer progression. If the patient is in a more advanced stage, usually Ann Arbor stage 3 or 4, they're given a combination of both chemotherapy and an anti-CD20 drug, and the combination seems to further improve the life expectancy of the patient. So our case is the case of Stephen Kim. He's a 56-year-old male. He went to the ER because he had excruciating right flank pain, which is pain in the back and the right side of his abdomen. A CT scan revealed that he had a kidney stone in the ureter, which was causing hydronephrosis, or the swelling of the kidney due to urine backup. And he also had enlarged lymph nodes in his abdomen region. For the kidney stone, the doctor put him on an anti-inflammatory drug and morphine for the pain. But for the lymph nodes, he went through a more detailed exam, which revealed that he had nodes in his neck, under the right arm, and near the groin. The biggest were 2.5 centimeters, which were located under his arm. But because the lymph nodes weren't what was causing the severe pain he was in, it was the kidney stone. So after he passed the kidney stone, he was discharged from the hospital. So he did go to his primary care physician, who referred him to a surgeon who performed a biopsy, and the biopsy confirmed that he did have follicular lymphoma. He was in a low grade. It was Ann Arbor stage 3, and he had an index score of 1. But because he was asymptomatic at this point, the doctor didn't start treatment, but he instead put him on surveillance for every 6 months. So he was originally diagnosed at age 56, and he didn't get treated until age 61, when his lymph nodes enlarged to be 3 to 5 centimeters. And it got to the point where they were uncomfortable and you could see them, and he had to start wearing turtlenecks because they were that visible in his neck. So the doctor put him on a combination of both rituximab and chemotherapy, and it did reduce the size of all the lymph nodes after 6 cycles, so that was a good thing. But then 6 years after that, he exhibited hydronephrosis again, but this time it wasn't because of a kidney stone, it was because of a lymph node in the ureter. So the doctor put him on a different treatment. It was rituximab and chemo, but this time it was a different combination of drugs in the chemo. And that worked for a year, but then the FL kept progressing, so he was put on Idealizib, or the commercial name is Zylodig, which is a P13K inhibitor. And that seems to be working because he's now 69 and his follicular lymphoma is controlled. So I want to talk about Idealizib for a little bit. The way it works is that it inhibits the P13K delta, which is prominent in B lymphocytes, so that's why it's specific for follicular lymphoma. And by inhibiting P13K delta, that's causing a deactivation of AKT and other downstream effectors in this pathway. So future experiments, researchers are looking to target pathway inhibitors, and they're moving more towards immunotherapy approaches. They are also looking into more targets in the B cell receptor signaling cascade, BCL2 and EZH2. BCL2 is a proto-oncogene, and EZH2 is a histone methylase. And also, novel antibody drug candidates are underway, which is promising for follicular lymphoma.